Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Hi, everybody. So some of the things that I'm going to speak about today have been covered already by Dr. Verma, because a lot of what Dr. Verma and I do is complementary. Dr. Verma sees patients with sleep apnea that are referred to him by primary care physicians. He also sends me patients. I see patients that are referred directly to me, who come to me. They find me in the phone book or they find me on the internet. And so a lot of the education that we give is similar. My practice is across the street. I've been in Fremont for 3 years. I previously practiced in Los Angeles. Sleep apnea is one of my particular interests. I think it's a fascinating and developing field, both for my own specialty as well as in general medicine. So I'm going to touch on some of the similar things, some of the same things that Dr. Verma did, but I'll try to move along so we can get to kind of the meat of the talk, which is some of the newer surgical treatments for sleep apnea. So just in terms of going over the generalities of sleep apnea, it's approximately 4% of women and 9% of men have it. I see probably at least 10 or 20 patients a week that are at some point in the workup for evaluation of their sleep apnea. And everyone that has risk factors ends up getting, a sleep study in my practice. Symptoms of sleep apnea in adults. Dr. Verma covered some of these things, but heavy snoring. We're talking not just the mild snoring, but the heroic snoring, the socially disturbing snoring, the snoring that wakes up your neighbors down the street. Excessive daytime sleepiness, high blood pressure, morning headaches, restless sleep, depression, anxiety, short-term memory loss, intellectual deterioration, temperamental behavior, poor job performance, impotence, dry mouth upon awakening, and mouth breathing. These are some of the many symptoms that can be caused by sleep apnea. We study most patients with risk factors. I prefer, as Dr. Verma does, to perform the attended sleep studies because they give a lot better and more useful data. And with regards to the site of obstruction, Dr. Verma as well alluded to some of this. Most patients that I see in my practice have multi-level obstruction. And so if a patient's going to have treatment for sleep apnea, whether it's going to be non-surgical or surgical treatment, it really is important to identify all the different levels, because the treatments can be given both in non-surgical treatment, surgical treatment, and the dental appliances, and sort of in combinations to give the best and most optimal results for the patient. There are limitations to the surgical approach. There are limitations to the dental appliance, and there's limitations to the CPAP. Not every patient is happy with the CPAP. Not every patient that I have treated surgically has had complete success. And so even if the surgery is a partial success, oftentimes patients still require some other treatment, whether it's CPAP or the dental appliances. So this is an MRI. Dr. Verma also showed this that kind of demonstrates what some of the factors are that contribute to the upper airway and the areas that are collapsible. Up until about 10 years ago, it was thought to largely be associated with just the palate. Here's the roof of the mouth and the soft palate that hangs down. And it actually hangs down pretty far. In some patients, I see the uvula hangs all the way down to their epiglottis in the airway. This is the larynx down here. This is the tongue base. And up until about 10 years ago, this was recognized as maybe only 1% of the overall cause of sleep apnea. And that's really changed in the last 10 years. We've increasingly recognized that the tongue base plays a very important role. Other locations that play a role include the nose. This is what you look like when you're upright. Not exactly, this is a cartoon, but air passes fairly reasonably through the nose or through the mouth, and there's good physiologic tone from the musculature that supports your airway and keeps it open for this collapsible part of the airway and the upper airway. When you're asleep, it's a different issue. There's a lot of areas that can collapse. We certainly have less physiologic tone. There's less energy. There's less signals being sent to our musculature in this collapsible part of our airway. And so there's less muscle tension keeping things open. And it has a tendency to collapse. So the nasal obstruction, the soft palate obstruction, invasive tongue obstruction, and then this generalized term called epiglottic or upper airway obstruction, which refers to the larynx. These pictures are right off the wall in my office. I often use these for patient education. In terms of tests that we can do to determine the sites of obstruction, a lot of what I do in the office helps me figure out what a patient would be a candidate for. Do they need maybe a nasal surgery? Do they need pharyngeal surgery? Do they need their tongue base operated on? And so these are some of the things that we can do in the office to look at the different sites of obstruction. In terms of the nose, starting with the top, there are three problems that I often see. And these include your septum's crooked, so your nose is blocked on one side or both, because in addition to having a crooked septum, you've got enlarged turbinates, which are kind of the pressure valve inside the nose. And some people have nasal valve collapse, which is the top part of their nose collapses when they breathe in. And that's actually the condition that those Breathe Right strips address. And these can all be fixed, whether sometimes surgically and often sometimes just with some nasal sprays in your nose. But never do I perform nasal surgery without performing other surgeries because it just doesn't tend to do enough to alleviate sleep apnea. One of the things I look at when I'm taking care of patients, and this is especially true in children who often have large tonsils, but it can also be present in adults, is the size of the tonsils. The left image shows, the absence of tonsils, and the right image shows these huge tonsils. And I have a few pictures from my office to show that. And it's funny because you'd think that patients that had this much space wouldn't have sleep apnea, and that's often not the case. Patients with this large tonsils very often have sleep apnea. The tongue position, which I kind of alluded to a few minutes ago, is also an important thing. This is a staging system that was developed by a guy named Dr. Friedman, and this was published a couple years ago. And the position of the tongue is actually predictive of success of some of the surgical procedures we do. And the bigger the tongue, the less successful some surgeries are, because essentially the tongue is causing more and more on a percentage basis of the obstruction. This is a patient that was in my office that has, obviously huge tonsils, and their problem will likely just be alleviated by the removal of those tonsils. This is a patient with a very long palate. You look inside their oral cavity and you see palate. You should see a nice arch below the tongue. And this is a patient with an obviously huge tongue. This is kind of an extreme example. This is a patient whom surgery probably won't help, because there's really no feasible way to get this huge piece of meat out of the way. And so things like a dental appliance possibly and CPAP are probably best for patients such as these. So other sites of obstruction, which I didn't delineate but can be included, are the level of the epiglottis, which is actually quite rare. Some patients have stenoses at various locations of their airway, and then lateral pharyngeal wall collapse. So the way that we treat CPAP or sleep apnea is multiple. Behavioral changes are always going to play a role in the treatment of sleep apnea. CPAP, Dr. Verma alluded to with continuous positive airway pressure, the dental appliances, and the surgery. And we'll touch on each of these with the exception of the CPAP, because that was the point of Dr. Verma's talk. In terms of the behavioral changes, weight loss in patients who have sleep apnea is essential. I have patients in my practice who you wouldn't think are overweight, but weight loss always helps sleep apnea, is one of the many factors that contribute to it. In terms of weight loss, we're 80% what we eat and 20% of what we do at the time that we're not eating in terms of exercise. In terms of diet, just a couple tips, more veggies and protein and less carbohydrates and portion control. Over the last 30 years in America, the plates at any restaurant you go to have gotten quite a bit larger. If you're eating at home, use the salad plates. They're smaller, and it'll be a lot easier to do portion control by using small plates. Exercise is the other issue. Every year after the age of 35, you lose about 5% of your muscle mass. That muscle mass supports your pharynx when you're sleeping. You lose your musculature in your tongue, you lose the musculature in your arms and in your legs. And so any patient who's going to undertake an exercise program to try to lose weight, strength training is important in terms of a role. We have a tendency to want to go and get on that treadmill, but it's actually strength training which is going to increase our basal metabolic rate over the long period of time and decrease our weight over time. There are a lot of excellent resources here at Washington Hospital with helping with these behavioral changes. There are clinical nutritionists that can design specific and custom diets for patients with health issues to try to pull weight off. There's endocrinologists that are here in the community, both as a part of my group at Washington Township Medical Group as well as other endocrinologists in town that can look into a lot of the hormonal influences which can increase your weight. Exercise is important, and I am an avid athlete, and exercising with the group always helps. It always makes it easier. It's really hard to get out of bed if you're going to go do it by yourself in the morning. Dr. Verma alluded to some of these things, and he showed you that really impressive slide. I kind of made this slide up on my own, but hormonal influences do play a big important role in sleep and how we age and how our bodies sleep as we age. And these are some of the hormones that can play a role. Human growth hormone, we've all heard about that. It plays an important role and declines as we age, and it may affect our sleep. Thyroid hormones, somatostatin, epinephrine, insulin, ghrelin, cortisol, all of these play a role. This is just an interesting slide that I wanted to throw in here. It looks at the different types of sleep that you see as you age. And in the upper left-hand corner, the slow wave sleep, which is that deep, deep, deep sleep, that is the sleep that's important to make you feel rested in the morning, that declines as we age. So part of that is just a function of aging. The other thing that also decreases is the growth hormone is also released less as we age. And then also the evening cortisol levels tend to go up. And so your REM sleep also goes down too. And so part of what we see in terms of the decreasing quality of the sleep that we have has to do with just aging itself. And there's research that's ongoing to look at how we sort of flip this on its head so that we can all get better rest and hopefully support other parts of our health better as we age. This is an interesting chart that I pulled from an unrelated study, but it looked at patients that had sleep apnea and had treatment and what the effect on their human growth hormone levels were after treatment. I have a particular interest in human growth hormone in that human growth hormone is shown to increase your lean muscle mass, improve your insulin metabolism, and decrease your insulin resistance through a variety of ways. It's kind of a complex thing. But you can see here, patients with sleep apnea tend to have a lower HGH secretion during sleep, and patients have a higher HGH secretion once they've been treated for their sleep apnea. And this plays into the whole issue of behavioral issues with regards to weight loss. A lot of patients that have sleep apnea find it's very difficult to lose weight, irrespective of being sleepy. And it's thought that some of these hormonal issues may make it difficult to sleep. That is, if the HGH is low, it's going to be really hard for you to metabolize that fat and pull the weight off. Medical management of sleep apnea, which is CPAP, the treatment is a good treatment, and it is the treatment that is the standard of care. It is 100% effective if you can use it, but by its nature, the compliance is low. There was a gentleman in the audience that said that every night he takes it off. The CPAP only works if you wear it. There are a lot of problems that go along with CPAP, and that requires a good relationship with your sleep doctor to sort of alleviate all these issues and then get all these things addressed to optimize your sleep. The dental appliances are something that we see more and more advertised on television. They are generally made by dentists. They're generally not covered by your insurance and can cost between $400 and $6,000. They, just like CPAP, are often uncomfortable. Patients tend to spit these out in the middle of the night. They can lead to problems with temporomandibular joint disorder that in patients that don't have it. In patients that do have it, it can make it worse. Sometimes it makes it better. This is a picture of a patient who wore a dental appliance for a number of years for his sleep apnea. And there's not a picture that goes with this, but it does change the way that your teeth come together. It does change your occlusion over time. I have a patient who is a dentist, and he has sleep apnea, and he made his own appliance and wore that appliance for 10 years. He came into my office for ear pain. Turns out he had TMJ. And the TMJ was caused by the oral appliance that he had built for himself. And his teeth looked very similar to this. And he was in the process of getting braces to bring his teeth back in alignment. So the oral appliances may be as effective as the surgical options, especially in patients that like to sleep on their backs. The place where dental appliances sort of fits in my practice is patients who can't tolerate the CPAP, who don't want surgery, who tend to have disposable income, and patients who especially have mild sleep apnea. I don't find that the dental appliances are very effective in patients with severe symptoms because they just do not do enough. And then moving on to the surgical options, which is the main focus of my practice, there are a whole host of different procedures that are done by a number of physicians, both in my own specialty, otolaryngology or head and neck surgery, as well as done by oromaxillofacial surgeons with dental training. And these range from pillar implants, which are something new on the market, and I'll touch on those briefly, uvula powder Pharyngoplasty, which has really been the mainstay of treatment for obstructive sleep apnea in patients, somnoplasty, snoroplasty, lateral Pharyngoplasty, the tongue-based advancement procedures, and so on. And when we think about surgical management, we always want to think about, well, as a patient doctor, what's the likelihood I'm going to get cured? And so the way that we measure it is, are you going to need other treatment? Or is the response a 50% or greater reduction in your respiratory distress index, which is the measure of sleep apnea? Or did we reduce your RDI to less than 20? Ideally, we like to reduce people's RDI or the respiratory distress to less than 5, which is in the normal range. This can sometimes be achieved, but sometimes it cannot. And certainly we look for symptomatic relief as well. One of the first line treatments that have been promoted since about 2002 is this thing called a pillar implant. Some of you may have seen something in the media about it. There are a lot of doctors who do this now. I was one of the early adopters of this technique, and I modified this slide. This actually came from the company to cross out moderate sleep apnea. And I don't even think I'd include mild sleep apnea. What it is it consists of 3 small implants which are made of Dacron, and they're inserted into the soft palate just behind the soft palate, hard palate junction. And what they essentially do is they reduce the vibration of the palate and sort of eliminate some of that vibration and tendency for it to collapse. In my hands, it's been not as successful as the company, as in many cases, would like you to believe. I'm very selective in patients who I'll do this procedure on. I usually only use it on patients who have primary snoring or have very, very mild sleep apnea and have tried other modalities first. 9 out of 10 patients that come to me specifically for the pillar implant get turned away. I'll do about 1 out of 10 patients. Some of the issues related to it is that you have to have a body mass index under 32, really no other risk factors, and the procedure is out of pocket. It's not covered by the insurance. It's easy to perform. This is a patient whom I performed the procedure on a couple of years ago. It's done in the office. It only takes about 20 minutes. You go home, you take some pain medicine, maybe the first day, and some antibiotics for a couple of days, and it's done. And usually you know within about 3 weeks whether it's going to be effective or not. But again, this is only for the mildest of sleep apneas and for the most part for primary snoring patients. As Dr. Verma indicated, if you're just a primary snoring, you have a lot of options. The options become more limited the more severe the sleep apnea are. So with regards to the actual surgery for sleep apnea, most patients have a multi-level obstruction. So I think it's an exception in my practice if you come to me for surgery and decide you're going to have surgery that I'll just do one procedure. Most of the things that I do for sleep apnea are done in conjunction with other procedures. So you need to address as many of the levels as you possibly can, and thus the procedures that you choose to do are tailored to each patient based upon their anatomy and the severity of their sleep apnea. Uvula powder Pharyngoplasty, done with or without tonsillectomy node, is what used to be done as a standard of care. And it was kind of a phenomenon where it was really the only procedure we had. So if all you've got is a hammer, everything's a nail. And some of the older research that was done on using uvula powder pharyngoplasty for sleep apnea sort of shed light on this, the fact that the success rate wasn't that high. In carefully selected patients, the success rate can be up to 80% success rate, both in the short term and the long term. In my practice, the tongue-based advancement procedure plays an important role in both moderate to severe cases, because in most patients with moderate to severe disease, I find that they often have tongue-based obstruction in addition to the palatal component. So in terms of getting into the specifics of the surgery for sleep apnea, uvula powder pharyngoplasty is probably the most commonly performed surgery. The severity of the disease is a poor outcome, is a poor predictor of outcomes. There are patients whom you would never think it would work in, and it works great. There are patients who you think it most assuredly would work in, and it doesn't work at all. So it's not entirely home run whenever you operate on patients. So there's a study that was done about 10 years ago that looked at sleep apnea and patients that all had uvula powder pharyngoplasty. And initially it all looked great, but if they went back and they restarted those patients at a year, they found that it had fallen off slightly. So this is a diagram of what was originally described for doing a uvula powder pharyngoplasty. And you just trim the tissue of the soft palate, which includes the tonsils, if there's any tonsils that are left after you get through your teenage years. And then the uvula gets resected. And the concept is you're trying to shorten the palate. And then you throw some sutures in here. And this is the post-operative result. I don't do this procedure because I feel as though it causes a lot of problems. Patients often complain that they feel that there's a tight scar band that's in the back of their throat. Some patients end up having some food go up their nose. This uvula is actually physiologically important. It isn't just there to, for Looney Tunes, cartoons for people to, do punching bags on Tom and Jerry. There was another procedure that was described in 2003, and better sort of describes what I do. It's called a lateral pharyngoplasty, and it was designed for patients with a narrow pharynx and not necessarily a long palate. And what is done is you resect the same portion of the lateral palate, but you leave the uvula in place, and then you just suture this together. Patients with sleep apnea very often have a lot of redundant excess tissue in their lateral pharyngeal walls. So what I do is I do kind of a mix of the two. The uvula is in a spring. Whenever you yawn, whenever you speak in a certain way, your palate's going to contract and it's going to raise up. And where the palate gets that extra tissue from is the uvula. So if the uvula is chopped off, that spring is no longer there, and that's why oftentimes if you've resected the entire uvula, you will have symptoms of, and you can read about this on the internet if you've done any research. Oh, doc, I'm miserable after my uvula fell up pharyngoplasty. I'd never do it again. I can't swallow. My throat always hurts. I always feel like there's something stuck in the back of my throat. And so this is my secret sauce to preventing that complication. I will trim off the uvula, but I won't cut the whole thing off. I always try to leave about 50% of it. It doesn't impact the results of the uvula powder pharyngoplasty, but it does make patients a lot happier in the long term. And so this is more of what it looks like after it's done. You don't have this huge elongated uvula anymore. You just kind of have a little bit that's left over, but it's able to perform its physiologic function as to act as a spring. As I talked about before, tongue position is a predictor of the success of uvula powder pharyngoplasty. The larger the tongue and the more of the oral pharynx or the oral cavity that it obstructs, the less likely is it that the uvula powder pharyngoplasty alone will be successful in treating surgery. Going back to one of the studies that have been done, looked at these different stages and these different oral cavity configurations, and found that as the patient's base of tongues got larger and the patients became heavier, the success rate went down. So doctors looked at, well, what are the options for treating that? And so we want to provide patients with success if they're going to undergo surgery. And so this is just a nice chart that sort of delineates the same thing, looking at the different stages. And patients that had stage 1 or, small, I'll go back and show you, the Friedman palate position was good, the tonsils, and they weren't too overweight. The success was good. But as the situation, the anatomy gets worse, the success rate of it alone gets worse. When you add a tongue-based procedure, this procedure was done, or this study was done using radiofrequency tongue ablation. Even in the worst of patients, the success rate was much higher. So coming back to the list of all the surgeries that I do, I generally do a hybrid of the uvular powder pharyngoplasty, and then I do some sort of a tongue-based procedure. And that is usually a tongue suspension procedure, and in some cases is a radiofrequency ablation. All of these have a variable success rate. There's numerous studies that were performed around the world, Asia, Europe, on various numbers of patients done by different doctors. So the success rate of each of these procedures is quite variable, and it really varies with the surgeon that does it. The key first is obviously patient selection. The type of tongue advancement that I do is called a repose tongue suspension. It's easy to perform. It takes you about 20 minutes to do. It's minimally invasive. I'd make a little incision, which I'll show you in just a second. I do it in conjunction with the uvular powder pharyngoplasty, and it definitely has an increased success over uvular powder pharyngoplasty alone. The only thing is that it's got mixed coverage by insurance carriers. And at one point, they were all covering it because there was a specific code for it, and then they came out with a new code, and that sort of mucked everything up, and the insurance companies decided to save some money and call it investigational, even though the data is pretty good. But what it is that it's a small screw that's placed into the back of the mandible, and then it's a little tricky thing, but you wire a suture which acts as a hammock. So when you're upright, you don't feel it. You don't really feel it when you're laying down either. But what it does is it prevents the tongue from falling back. It's not designed to cinch the tongue forward so much that you're kind of strangled or anything like that. But it's to act as a hammock, so you can jump and not hit the ground when you want to jump into something. It is done in the operating room through a small incision. This incision is probably twice the size of the incision that I have to do now because I've done about 100, and the incision is usually about 1 centimeter long. You make the incision and you dissect down to the posterior aspect of the mandible, and then you just use this special drill and pop the screw in, and then you lace this suture through one side of the tongue base, out, across, then back through, kind of creating a triangle. And then you secure it down with just enough tension to hold that tongue, and you can actually feel the base of the tongue, which tells you that you've placed it tight enough or too tight, and then you secure it down. And this is just the same picture again showing the completed procedure. So in terms of the clinical results of this procedure, this was a study that was done a number of years ago, and just with the uvular powder pharyngoplasty alone, with the repose genoglossus advancement, the patients had an average reduction in the apnea-hypopnea index of 81.7%, which is pretty significant. And the cure rate, which means that the apnea-hypopnea index was less than 5, was 67%, which is pretty good. That's 2/3 of patients, which is far better than it used to be. There was another study that looked at the same thing, and their overall cure rate at 3 years was a whopping 78%, which is pretty remarkable for a problem that has had a lot of difficulty. We've been having a lot of difficulty figuring out. And this is kind of a summary of the same studies. I've done over 100 procedures of this combination here at Washington Hospital the last 3 years, and the complications are pretty limited. I have one patient who developed an infection in the site where we put the suture in. I had one patient whose suture essentially broke or tore through the tongue base. And then I've had 2 patients that have had a taste disturbance. Their food doesn't taste the same again. One patient, it was fairly mild and went away, and the other patient says she can't taste anything at all anymore. So we're still waiting on her to see if it's going to come back. Other procedures that you can do on the tongue is this procedure called a genioglossus advancement or genial bone advancement trephine, where you cut a hole in the actual mandible and advance the tongue musculature through that hole and flip the bone across. And then the most aggressive is a maxillary mandibular advancement. And this is usually done in conjunction with oromaxillofacial surgeons. And you make a cut in the maxilla with a saw through the entire maxilla and down right behind the posterior teeth. And then you do the same exact thing right through the mandible on both sides. And then you advance the whole thing as a unit and put plates on. It's pretty aggressive, and it's reserved for only the worst of the patients. I don't perform these. I refer these out if patients require it. And this is, you know, for patients who have failed everything else. And then the last thing, I guess, which is kind of something I've been thinking about doing lately. You can find this anywhere on the internet, and just enter oral pharyngeal exercises for sleep apnea. There was a study that came out of Brazil last year, and what it looked at can we influence patients' sleep apnea by just doing exercises with our oral cavities, with our cheeks and whatnot. Because essentially, as we lose muscle, there's not really a good way that we can, you know, pump iron with our tongues and with our cheeks and so forth. And so they devised some exercises, and they were actually able to show in this small study that their sleep apnea did improve in some of their patients. And so this is something that I'm starting to do with my patients to sort of help them along. And it's not something that we do independent of other treatments like CPAP or surgery or the dental appliance, but in conjunction with it, because essentially it requires a team to address in a sort of a combined approach to treat sleep apnea. So a lot of patients out there have sleep apnea. By the size of the crowd, it certainly supports that. From my standpoint, uvular powder pharyngoplasty alone does not sufficiently treat most patients, and so I also do a tongue-based suspension. And it requires a team approach. Dr. Verma and I work together very closely to try to give patients with sleep apnea the best outcome. So that's it. Any questions?
I think when we spoke, I mean, I find that even when I'm awake and standing up, if I start to walk or anything, I start to have to breathe through my mouth. This seems, and I think, although I couldn't remember and I couldn't find in my notes, I think you said that there was something you could do to, like, permanently keep the airways more open.
Sure.
And if there is, could you talk about that again? And does it make you look different?
Very good question. So sleep apnea, a lot of patients with sleep apnea have crooked septums or their turbinates are big. The turbinates are on the lateral wall of the inside of the nose, and in every patient they are large or small depending on a lot of things. Sometimes allergies can make them larger. Some people just have large turbinates just because they're born that way. So whenever there's a situation where there's a septum, which is the middle part of the nose, that can be straightened, which oftentimes will alleviate a lot of the obstruction. Typically, when I do surgery on the nose to straighten the septum, I'll also address the turbinates, which hang down on the side. And when those are reduced, whether you're sleeping or awake, you will be able to breathe better through your nose.
I use a CPAP machine, and it's like my teddy bear when I go to bed at night. I'm wondering if the tongue exercises will help. Do you have some handouts on the exercises?
I don't have them on me, but I can get them for you. If you want, you can want to call my office. We can print out, and you can find it on the internet too. It's on YouTube, as a matter of fact. And all you have to enter is oropharyngeal exercises for sleep apnea, and it pops right up. It's #1. So, and you just do those like 10 minutes a day. I don't know that it's going to help everybody, but anything that we can do to help patients with sleep apnea, I think is worth trying.